Good afternoon, everyone. Welcome back. Hope everyone had a nice break if you had a break, that is, and Happy New Year to everyone. We're excited to get going in 2026 with our CPD program again. So we have Walt Fritz joining us this morning. Well, this morning for Walt, this afternoon for us. Walt is in New York. So we welcome Walt and thank him for joining us. And thank you all for joining us also. Um, Walt will have a presentation for us, and I suppose as we go through, we invite questions to be put into the chat, and I can relay those to Walt as we go along. It is being recorded. Walt has kindly agreed for it to be recorded, so thank you for that also. And we will share a copy of the recording afterwards. So I suppose we'll get started. We'll ask Walt to maybe introduce himself and explain maybe how he got ended up teaching this to SLTs. So welcome, Walt, and thank you.
Yeah, thank you, Kathleen, and thanks for not making it any earlier in my morning than this. Because yeah, that was a bit of struggle getting to my office. But anyway, yeah, thanks so much for having me here and agreeing to do this. I'm Walt Fritz. I'm a physical therapist from the United States. Um, and I think it's a key question. It's like, what in the heck is a physical therapist doing lecturing or teaching work to speech pathologists? And I actually get a little bit of sort of occasionally a little bit of friction or a little bit of anger here. Some people wonder why, again, why is a PT or physio teaching speech pathologists? Why can't we do this ourselves? And it's like, well, you can. The way I look at what I do for a living when it comes to teaching is I'm not a speech pathologist. I don't pretend to be one. I don't know your background, your education, your training, all the patients you work with. Um, but I know a certain version of manual therapy really well. And I've worked with speech pathologists now going on 16 years directly with this class. And I kind of envision myself as meeting you in the middle of a bridge, giving you what I understand about not just manual therapy and exercise, but shared decision making, patient-centered care, and then sort of handing it off to you to say, okay, how can I make this relevant to my population? I think that's one of the most frequent questions I get with, well, would you use manual therapy with this diagnosis? Now, it's a logical question, especially for people who are really, I mean, we're very academically oriented, clinical brains saying, trying to do that decision-making tree. And I think it's a fair question. Would you use manual therapy with this sort of diagnosis? But what I try and get people to do is transition that question slightly. Instead of the diagnosis being the driver, what's the person's issue? What's their functional limitation? What's the quality of life that they're missing out on that they're coming to see you? Now, I'm a physical therapist here in upstate New York. I see head to toe people, but I also see people within your domain. I get referrals from ENTs or speech therapists for various conditions, and they come in with that diagnosis, but there's that intake, that sitting face to face, and where you ask them to tell you about that. How does that diagnosis affect you? How does it? And I mean, this is stuff I'm guessing I'm lecturing, or preaching to the choir, as they say, in terms of what you already know. But I think it's really, really important. I was just telling Kathleen before we started, I was in November, I taught 3 classes in India. Very different clinical mindset there. It was a very different one for me, where that were questions that I continually got repeatedly asked. What about this diagnosis? What about this diagnosis? And that's where I really realized that I need to accentuate the message that I just gave you. Think of the problem, the functional quality of life issue, over the diagnosis. And I think that might guide you a little bit more here. All right. I got started in this purely by accident. No, not purely by accident. I guess it was a planned accident because I have a big mouth. And I like to write a lot about my big mouth's findings on the internet. So back in, I don't know, 2011 or 12, I think I'd written an article or two about some of the fortuitous accidents that happen here in my clinic. Basically stories like, I'm working with this patient with their neck pain, and we start moving into, well, the front of the neck, where we're working on maybe the disc or the cervical nerve roots. And I would get a patient say to me something that I'd never heard before, right? I'm moving into this space behind the sternocleidomastoid. Essentially, now I know in that space between the front of the spine and the back of the larynx, which is where I was taught originally to go for cervical disc issues. But I started to encounter some things that, um, well, they weren't things that I learned about. People talked about the pressure in their throat, replicating an issue with swallowing, minor stuff, right? Not major dysphagia from surgery, et cetera. But they started to say things to me that really got me curious. And because of that curiosity, and because I had a blog and blah, 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 I just started to write about it. And somehow that caught wind of a speech pathologist in Chicago who was running a one of class in 2013. So she asked me, as well as Benjamin Asher, who died a year or two ago, an ENT who had written a number of times in the Journal of Voice on using manual therapy for muscle tension dysphonia. And they invited the two of us to give this class. And, it was a little rough. It was a little rough from my part because I had been teaching physios and massage therapists to that point, and I didn't have the language to speak to you, or at least to pretend I could speak to you. So I just inserted some words that sounded more, speechy, and I thought it was really rough that first class. But the feedback was actually really quite positive because it was a unique opportunity, I guess, in the United States for speech therapists to have exposure to learning some of this work. Now, I know in Europe, you have various people who might be teaching manual therapy in a live setting. Jacob Lieberman, for instance. I trained with Jacob actually back in the UK right before COVID. And I owe a lot of gratitude toward Jacob in terms of learning a lot. I think I learned more about the surrounding aspect than the manual therapy itself from him because he's very different from the way that I both treat as well as teach. Although now, and you're going to see in the video that's going to be at the end of my talk here, I've incorporated some of those laryngeal manipulation principles. But a lot of people who you might have an opportunity to learn from in the UK, et cetera, et cetera. United States is very different. Very few people are teaching this. So I guess I hit the right place at the right time, at least in the United States, in terms of saying, hey, I think I'd like to teach this. So back after 2013, I kind of took a year or two setting this up. And then with the help of a number of speech pathologists who have been my mentors, kind of started presenting this to speech therapists. And every time I teach it, every time I rewrite a manual, every time I redo my slides, I think I can hone it in more to the unique needs of you and your mindset, your patient populations, et cetera. All right. Another question people often ask is, well, what about age groups, right? Can you use this work with pediatrics? Can use it with dementia, can use it with head injury, right? We're sort of skirting that diagnostic label, but we're asking those similar questions. And, the way I answer that one is we learned manual therapy at university and I graduated in the mid 1980s. It was a regular part of our curriculum. My first nearly a decade was spent in pediatrics, early intervention, developmental disabilities, that sort of setting, group homes, et cetera. And yeah, I use this work with my early intervention population, with the developmentally disabled. Is it easy? No, but nothing in pediatrics is easy. We learn the core of it, and then we learn to adapt and modify it. And I think we can use the same filter when it comes to dementia, head injury, etc. And another confusing piece of this work is the identical technique that I might have one person use for somebody, post-stroke swallowing, they might use with an elite level performing singer, which sounds confusing, but it's a core set of principles, not just what we do with our hands, but what we do with the engagement that becomes the really important piece of this, right? So I really, really, really appreciate an engaged audience. And that could be once in a while, just wave on me on the screen if your video's turned on. But I love questions. I love comments. I love feedback. I love to make this about answering your questions, and hopefully you have questions, not just me sort of lecturing you. I resisted PowerPoint slides for so many years, but then last year I finally started using them, but I promise not to totally read my slides to you because what's the point at that point? What I want to do now is just take a minute here and share my screen. And we'll switch over to Okay, so I'm a bit of a fumbler when it comes to PowerPoint, so you'll have to excuse me here. This is the name of my seminar program, Manual Therapy for Voice and Swallowing Disorders. as I teach this work, I see not just in the speech pathology community, but in the general community of therapists, what people think manual therapy is, right? And I think some of these are pretty simplistic and logical. They seem to align with sort of that mindset of the people who do manual therapy, right? Maybe physios, maybe massage, maybe osteopath, et cetera, right? It's a very skill-based treatment to correct peripheral issues. That's kind of how I learned this work and practiced it for decades. And that it's the training on anatomy, on origin, all of those things on kinesiology that we need to know to be a safe and effective manual therapy operator, right? It's another example of what I term a clinician as expert intervention. Now, doesn't that sort of summarize the biomedical model, the clinician as expert model? People come to see us because of our expertise, because of our knowledge, experience, and skill level. And that's an easy sell because it's who we are and what we do. Um, and when people come to my class, that's kind of what they're thinking. And there's also probably some anxiety about, well, gee, I don't know if I could do this. I never learned this at university, hadn't had much training on the job. And I don't know whether I could have the skill and palpation that somebody needs to be a safe and expert manual therapy provider. And it's like, well, but my class is different. This quote right here is it forms the foundation not only of my workshops, but how I, as a clinician, view the work that I use. Because manual therapy traditionally was seen as something we're doing out there in the periphery. The skill to find it, figure out what to do with it, and then fix it, right? But the new models of manual therapy are pointing the locus of change not out here, but up here. And I think that's where, especially for the newbie coming to this sort of workshop or interested in training or et cetera, I think if you can view this not just as this, oh my gosh, here's this unique skill set, but you're still going to be using the skills that you have. You're just using touch as the form of communication. And I really like to reassure people that the model that I present, I believe makes it easier for a newcomer. The models that traditionally are taught do require almost a tiered level of training where it's like, okay, here you take the intro class, now come back in 6 months and take my next level, next level. And all of that stuff is helpful. It's kind of how I learned this model. But I don't feel like we need that level of training in order to touch another person in an effective way to help them feel empowered to help themselves. And that's what this model is about. It's about shared decision making. It's about empowering each and every one of our patients to see that they have an understanding of their own lived experience that me, the clinical expert, will never have. This model is equally about the manual therapy as it is how we present it. All right. Um, Now, the downside of having my slides show up on screen is I don't think the chats show up. So if anybody's popping a question up about anything I'm saying or not saying, Kathleen, if you could let me know verbally, okay?
Yeah, I'll let you know.
Yeah. So I actually just added this slide this morning because I think that's a basic core thing that we have to look at. That in the United States, and I hate to keep speaking for the United States, but I am American. I'm not exactly proud of that at that point, this point in history. But in the United States, it's a relatively clear line where because manual therapy has been included in the speech pathology literature literally since 1993. It's talking about dealing with disorders that within the scope of practice of the speech pathology, and it identifies speech pathologists as a target population for this. The American Speech and Hearing Association scope of practice law for a speech pathologist allows manual therapy. Now, I can never speak for you as an individual, nor within your region or country. But it's my understanding, especially as I travel around the world a lot, that it basically is the same kind of lens that we're looking at, right? Although you may not have learned it in grad school or in undergrad, your peers may not use it or do it. I think it's something you need to examine first, not just from a legality, but an ethics perspective. Do you feel qualified using this work? And it's a question you have to answer for yourself. If I was presenting to you that clinical model where no, 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 you have to wait until you're an expert to apply it, I think a lot of people get sort of shy from trying it. If I, not to over empower you, but if I empower you that, maybe this work isn't as hard as we think. Maybe it's another form of communication. What happens when you touch somebody? There is more involved to this work than just touch. But yet I use a lot of the foundational science that underpins touch to explain some of the effects of the work that I use and I teach. So this is a question you have to ask yourself. Is it within my scope of practice? As far as I know, it is. Um, and I'm gonna, this early part might be a little boring, or maybe not to you. I don't know who it is or who you are, but manual therapy, I use those words. Prior to 2020, everything I taught was called myofascial release. Um, why? Because that's how I learned this work. All right. I learned that the problem is restricted fascia, connective tissue, where the connective tissue stops sliding and gliding and becomes adhered to each other through injury, trauma, surgery, radiation. It was this very narrow niche model that I learned. All right. But then there's all these other models, and I just picked a couple to put up here. Maybe the one that you might be more familiar with is manual circumlaryngeal treatment, circumlaryngeal massage, or laryngeal manipulation. When I come back away from the screen, I would love a show of hands to know who in the group here has taken any laryngeal manipulation training, whether it's formalized or maybe on the job, right? And laryngeal manipulation has been shown to be the earliest model of manual therapy that was included in the manual therapy literature. And I'm going to talk about that in just a second. But you've got studies and papers in your literature on myofascial release for voice, swallowing, etc. You've got some for vocal massage or other sorts of sort of name terms. I don't know in Ireland if myofunctional therapy is a thing with speech pathologists. In a lot of other countries, a lot of speech pathologists take the niche training in orofacial myofunctional work, right? Because a lot of times then after a tongue tie release, the person will be recommended for craniosacral therapy. Again, all of these seem so completely walled off. Craniosacral therapies, is said to be different than circumlaryngeal treatment, et cetera, et cetera. And they all have the walls that they sort of build, I guess, to sort of elevate the views that they view as important, as well as the name of the technique. But I've been in this world long enough, in the manual therapy world, to know that there's not a lot of differences between these models, except the battles we fight on social media on why they're different, right? Sure, there are differences in the method of touch. I learned laryngeal manipulation from Jacob Lieberman and some other people, where I'm going to use the word aggressive, and I don't want to use that word in a negative way, but it is more aggressive. It's more assertive. It involves the clinician trying to break that muscle tension. All right. And the research has shown that it's effective. I argue that, all right, that helps, but is it always necessary? Can we have more of a continuum of style and pressure to work from instead of it being something that the clinician decides is best for another human being? And you're hearing the nature of me and my approach here. Instead of me feeling like I know everything, what I try to do is share these decisions with my patients, if possible. Some people love this aggressive work, whether it's on the larynx or anywhere in the body. Some people completely abhor it. It just feels dangerous to them. I want to see if I can work in this continuum to say, okay, here's how we might start, but patient, what do you think? What do you feel? Does this feel safe? Incredibly difficult question to answer for some people. Does this feel safe? Right? Does it feel like it might be helpful? Another really hard question, but I love giving my patient this potential input. They might not be able to answer it, but I want them to at least have the opportunity to be offered that chance. Here's a little bit deeper here. Manual therapy, historically, is viewed as a peripheral technique where it's all about what you and I are doing out here. Laryngeal manipulation, even in papers released, well, I've not read any 2026, but in 2025, laryngeal manipulation is very frequently still worded as a peripheral problem too much muscle tension. And the effect is, well, we break that tension because of local tissue responses. Now, there's a clean, subtle logic to that. You got a problem here? Let's fix it out here. I call it the what happens in Vegas stays in Vegas perspective. As if, whatever happens here, we're going to fix out here. And it's a nice story, but it's really incomplete. Now, across the bottom there, don't worry about some of these. A lot of these are more in the manual therapy general literature. But that whole progression of those three papers represents an evolution from peripheral to multifactorial. Finally, Nelson Roy in 2019. Now, I don't know in Ireland how much exposure you have to Nelson Roy. Nelson Roy is a PhD speech pathologist from the University of Utah who has been the most prolific researcher when it comes to using manual techniques for muscle tension dysphonia. His first paper, along with Leeper in 1993, was the introduction to an actual research study using Arnold Aronson's original theories on voice disorders. All right. So Nelson Roy started in 1993 and he continued through the 2000s and through the 2010s. And what I love to say to my students when I'm teaching this work is if you could take, and I don't know how many papers, let's just say 10 papers. If you could take Nelson's 10 papers from 1993 to 2019 and lay them out on a long table and spend some time and read them, what you're going to read is a modernization of a narrative, of an understanding. From in 1993, now, while Nelson did not use my phrasing, it's what happens in Vegas stays in Vegas. There's too much tension here. Let's break it up, right? But then you start to see a maturation in the language because we understand more. Until 2019, it's a study called the Neural Bases of Muscle Tension Dysphonia. Picture this for a second. It was a one-person case study, so take that for what you will, all right? But they took a person, a patient with muscle tension dysphonia, and what they did then was they put her in an MRI and they gave her a script to read while she was in the MRI. They turned the MRI on and they had her read the script, and then they recorded the activation pattern of her brain while she was reading with the muscle tension dysphonia characteristics. What they witnessed was a very dysregulated, typical brain pattern of someone with muscle tension dysphonia. Got it so far? They pulled her out of the MRI, they sat her up, or however they did it. They did the equivalent of a session of laryngeal manipulation, laryngeal reposturing, and then I'm working to get a more normalized voice. Very typical protocol for laryngeal manipulation. Once she was able to hold a more normal voice, about an hour later, they slid her back in the MRI. They gave her the same script and they asked her to repeat where she started. And what they witnessed was essentially a completely different reading. What they saw from before to after was her brain activation activity patterns went from dysregulated to regulated. Nelson does not say, see, it's not here, it's here. But the implications from that research, from both what I want to say is both the causation effect as well as the treatment effect, is that it's a blend. It's a cascade from peripheral to central, and in terms of interventions, potentially from central back down to peripheral. What we're seeing in the speech pathology literature now is a maturation of the narratives identical to what's happening in the outside community. All right. To some people, that doesn't matter. My big thing is about seeking and understanding the complexities of the mechanism of actions of the work that I use, as well as the work that I teach. And here's just a few more studies here. I'm not going to belabor this too much. Early studies, Aronson, it's actually, you could say Aronson 1980. Arnold Aronson, in his first edition of Clinical Voice Disorders, introduced the idea of using manipulation here. But he had a key phrase in that paper, in his book, that I think got misinterpreted over the generations. In Aronson's first book, and then 1990 again, he talked about that persistent voice disorders often don't respond to more gentle interventions. If you read the context, Arnold Aronson is talking about more gentle interventions, meaning traditional voice interventions. But what that statement, I believe, got misinterpreted as is less aggressive manipulation doesn't work. You got to be really aggressive. And I read it over and over in subsequent papers where people talk about the need to be aggressive. And I think they truly misinterpreted Arnold Aronson's original intent. All right. Anyway, we move through that sort of continuum. What happens in Vegas stays in Vegas, acknowledging central nervous system influence. And then again, finally, Nelson Roy's study in 2019, understanding the true complexities of any disorder we're working with, right? Differences in the models. I already talked about this, right? Clinician is expert in traditional models, but you know what? Patients accept that model quite readily. You are an expert. They easily defer to us for everything, not just for manual therapy, because we are the expert. And we are the expert. But what I like to say is my expertise ends where the unique lived experience, patient preferences and values starts, right? What I'm trying to do in my model is to acknowledge this missing half from the traditional biomedical model. The difference in this model is primarily driven by shared decision making. Right. And if you're not familiar with shared decision making, it's making inroads into basically every one of our professions. Number of really nice papers being written within your literature. But I owe a debt of gratitude to Leah Halou. Leah Halou is a PhD speech pathologist out of the University of Pittsburgh. And in 2017, she released her first paper on metatherapy. Metatherapy. Now, Leah's both research as well as patient population is with transgender voice. And in her papers on metatherapy, what she talks about is, I'm going to paraphrase a bit here simplistically for you, and then tell you the link to what we're doing here in the work that I'm teaching. Leah said that basically when a clinician comes out of training, university, et cetera, they have the tools. They have the basic skills of using and applying the tools, the interventions in appropriate manner. But what often happens is using the tool correctly, they don't get the outcomes that somebody who's been doing it for many years gets. Even though, as an observer, you watch the new clinician using the tool, and you watch the skilled clinician using the same tool, they're using the same tool in the same way, but there's a difference between those. And what she called that is the meta. That the tool, the intervention, straw phonation, lip trills, etc., because she mentions those in her paper. The tool is the therapy. They're all using the tool properly, but how we embed it, how we envelop it, the experience, the mentoring, everything we've learned about applying that tool becomes the meta that really makes our intervention probably more impactful than just the device or the tool or the modality itself. And she's talks about the meta as being almost more influential than the tool itself. Now, she's written a couple of solo papers, 2017-19, plus she's written some other papers with some people who I think are really prominent people in the field when it comes to actually applying the granular aspect of metatherapy. The reason I bring this up is I had the pleasure of teaching one of these 1 hour type of in-services to the University of Pittsburgh. And as I was presenting my shared decision-making model, trying to elevate patient preferences, that's when she stopped me. And Leah said, "Have you ever read my papers?" And I hadn't. So we decided to give me some chance to read the papers and then meet again one-on-one, just her and I. And what she described to me was what I'm describing in this approach is that we think that the important driver of change is the tool, the technique, the way I address things. And it is important, but it's the context that it's applied, the shared decision making that we ground this work in, that really becomes the instrumental part of it. And I'm not trying to sell you on anything here at all. Well, maybe I am. I'm trying to sell you on understanding that the tool is just the metaphor to get there. It's how we envelop it. And if you take a look at your own practice, you'll see that metatherapy is a primary driver. And what I love about Leah in terms of what she gave me a foundational grounding for my work as well as the theoretical aspect of the work I teach. And there she is right there. That's the specific paper we're talking about. All right. I'll make available a reference sheet from this tool that I'll send off to you, Kathleen. If anybody's interested, if the papers that I mention in these slides here, these brief slides, interest any of you, though, feel free to reach out to me via email or social media. I don't mind just sharing the papers with you directly. Um, I picked another paper, not to get too enmeshed with some of the details of this, but this is a really interesting paper because my work is quite different from the work of others. I told you before, traditional manipulation is like this. It's while there's some continuous touch because I'm holding the larynx, there's a lot of non-continuous intervention going on. There's a constant movement. It's a paper where, let me just sum it up briefly. They had a person who they had their head wired with electrodes, so they knew brain pattern activation, et cetera, right? Then they laid him on a table. And then down at the foot of the table, the clinician was. And the clinician was told, I want you to take two fingers and touch the inner and outer ankle bone. And I don't want you to do anything except focus on your touch. Pay attention to your touch. I think in a way they were saying, think loving,
Absolutely,
think,
less impact on.
sorry about that. Think loving thoughts down here at a person's ankle, right? Don't do anything, just touch with intent. But there were two groups down here. One group had headphones on, where they were being blasted with loud random noises under the assumption that those noises would interrupt their ability to pay attention, to focus, right? The other group, there were no headphones. They were just allowed to just pay attention. And what they did then was they watched what happened for a long period of time. They watched what happened in the patient's brain. Did centers in the brain begin to reorganize in terms of what became more alert, what became more at rest, that sort of thing? And what they saw in the group where they had the headphones on, where the person was trying to pay attention but was getting blasted with this noise, was not much changed up here in the patient's brain. But in the other group, what they saw was a slow opening of the attentive centers of the brain. Now, if you're into neurophysiology and neuroanatomy, go to the paper, look at the parts of the brain that became very alert and aware. But what you're going to see is some of the mutual parts of a person's central nervous system that we actually desire to be alert and reactive during any kind of our interventions, whether it's touch-based or education-based or whatever that might be. What they saw was essentially the person became alert, aware, and attentive and receptive. And the cool part to me, and yeah, I cherry picked the study because it aligns well with all my biases, is that attention peaked at 15 minutes. 15 minutes of continuous touch caused that brain to become most alert and aware and receptive. Right. And I think that's really important. Sometimes, now this really, I think, puts some people off. Sometimes I hold a technique for 15 minutes. Not saying you have to, but that's historical for me. That's how I learned this work, right? But a longer touch is not better than a quick touch, but it offers different opportunities. And that's what this is about, is offering as many different opportunities to reach another human being as possible. All right. Now, I am going to, let me see. Oh, there's the chat. Okay, good. If you have chat open, there we go. Okay, so I just dropped this paper. I In 2024, I published my first ever research paper, yay, Walt. And it was essentially taking a look at some of the problems in the industry that, despite what we know in the laryngomaniotherapy literature, they're still talking about what happens in Vegas stays in Vegas. Not everybody, people are understanding that's more nuanced, but all this paper is about not a shaming or condemning, but an invitation to understand that even something as simple as doing this is a very complex act on us, on our part, but also a very multifactorial potential influence on the whys of change. All right. So that paper is there for you if you're interested in it. All right. Now let me move on here. Okay. So the core of this approach is it focuses on a therapeutic alliance, and it's just basically a maturation of those older, I call them tissue-based type models. A lot of people will argue with me and do argue with me that those tissue-based beliefs are very active and valid still. and I guess it's just a differing opinion. All right. Um, I participated in this fun little exercise many years ago on the internet where we had a sort of a round table, a virtual round table, where people were saying the question that we were addressing was, and here's what I want you to think about for just a moment. If somebody asked you in your professional capacity, what paper would you pick to bring to a round table to say that this paper forms the core of my beliefs, my approach? Now, it doesn't necessarily answer all the questions, right? But if you needed to or could pick a study or a body of work, what would you pick? And this was primarily physios and massage therapists in this group. But so you were getting all these papers on trigger point therapy, et cetera, right? And when it came my turn, I picked that first paper that's older than me by 2 years, by a psychotherapist, Carl Rogers. And when you look at the historical context of that paper and what happened with that paper, it was a paper that, in essence, got Carl Rogers ostracized from many in his profession because he had the audacity to go against the grain. In 1957, the prevailing belief was that the primary driver of psychological change is the choice of the correct modality. All right. Um, Much like in the therapeutic communities today, choosing the right intervention, the right tool is key to change. But what Rogers was saying in his paper was that the choice of the tool matters less than the relationship that you build. Now, I think he probably said it in a way that maybe was abrasive enough for his peers to get really offended by it. I don't know. But I think it's fun because he kind of like had to follow that path. No, I followed the path that he did when I started to question authority in this field. All right. So to me, that laid a blueprint for me. Think about the relationship that we're building. Now, 2018 by Misiak, that's a paper in the physical therapy literature that basically modernizes Carl Rogers' concepts. And then Sahlberg, a much newer paper in the speech pathology literature, applies it directly within the context of your profession. Um, Okay, so Jennifer, let me just pop into your question for a second. I have never ever seen a study that is so nuanced as Seratelli's study when it comes to neurodivergent individuals. I actually I put this out there on social media about a month ago. I would love to see if somebody like Seratelli, with that continuous touch, would it matter if the clinician had a glove on? Would that little bit of latex or whatever your gloves are made of, would that change what happened up in the patient's central nervous system? And there's no research on that. I just think it's an interesting topic. Why do I bring that up? Because when I teach, well, as a physical therapist, we were never taught we needed to wear gloves when we touch a patient. But as I observe speech pathologists around the world, I would say at least 75% always wear gloves. I don't have a problem with it. It's a different ethic to me. Does that make a difference? I have no idea. I can tell you though, when it comes to neurodivergent populations in general, I have to be willing to be flexible with touch, the kind of touch, how I touch, any barriers that we might need. I was taught this work in a way that said I need to be working directly on a person's skin. That's just the native inherited type of narrative of manual therapy. But a lot of times that touch isn't allowed. That touch isn't appropriate. My touch directly on a person's skin doesn't feel safe, right? So I do a lot of what I call shielded work. If we're working with somebody who's got, some radiation, some fibrosis, and maybe some pain, that person may not feel safe initially of allowing me to put my hands right here. So I'll often invite their hands up here. And they put their hands here, and then I put my hands over. And I model that throughout the body. I've used that with people, children and adults who have tactile issues, right? Allowing that locus of control, that boundary, so they have the ability to withhold, to protect, to guard, etc. Right? I had a really interesting experience last summer. I was teaching in Athens, Greece, and one of the therapists in that room self-described himself as autistic. Okay. That was the word he used. And when it came to tongue work, because in my class, the entire second or afternoon of the first day is all tongue work. We use gauze. We use what I call cotton finger cuts. We need something in order to grip the tongue so we can then engage the tongue, right? And this gentleman found all of those incredibly offensive. He could not stand the textures of any of those textures on his tongue. So we had a chat at the end of the day. And what I asked him to do was to go home tonight and look around the house. Were there any fabrics that felt less offensive to him? And he came back the next morning with something, smoother, silkier, that sort of thing. And when he then said, okay, partner, go ahead and try it, what he described was, okay, that's a little easier, but it's still really icky, right? But if he came up and had his hands here, and then I put my hands over his, that allowed him that boundary, that sense of control, which he didn't love it, but it was tolerable. It was doable. All right. So good question. Thank you for that. I don't know. It doesn't necessarily specifically answer, but we've got a quarter full bucket of manual therapy literature right now, in specific to the speech pathology profession. I say a bucket. It's a bucket that's got thousands. Maybe that's an exaggeration. Many hundreds of papers, but they've not gone into that level of detail that I'm aware of. All right. Um, okay. So back to business here. Uncertainty. I feel incredibly comfortable just wallowing in uncertainty. And what I mean by that is, well, people ask me, well, what tissue do you think is involved? And I'll say, I don't know. Now, I used to say it's your fascia. Everything was a fascial problem when I was doing myofascial release. But the more models I learn, the more I realize there's no way they can all be right. Can I know with 100% certainty that the tissue that I'm palpating not only is in spasm, right? Because we can feel, for instance, when a masseter is in spasm, but can I know with 100% certainty that that muscle in and of itself is both the cause as well as the primary target for my intervention when I do work here? And the way I like to annoyingly answer that question is not without a scalpel. You can't. Because unless I can cut open the skin, et cetera, and get directly to that masseter, I can't guarantee that all treatment effects are solely because of that masseter muscle. There's so many possibilities. The more I learn, the less of which I'm certain. And uncertainty is almost the antithesis of what an expert should express. So there's a lot of discomfort initially with this model, but knowing more allows you to say, I don't know. It could be this, it could be this. But what do you think? Does any of this feel safe, useful, helpful? The same thing. All right. Some of my personal philosophies you're getting here. Now, Visible Body is the app that I use for things like this. When I just chose a random image here, and before I took a screenshot of this, I did a lot of dissecting away, obviously the skin, connective tissue, a lot of the cutaneous nerves that there's literally just tens of thousands of cutaneous nerves that come to the surface that needed to be stripped away. Models that teach nerve-based intervention, even some of the major nerves, we can see the facial nerve, et cetera, in there. How can we know when we try to get at that masseter muscle that the problem and the effect isn't driven more by the facial nerve that feeds, that fuels and drains, if you will, that masseter, right? It's a very complex multifactorial potential. Uncertainty to me, if you word it right, actually lets people know that you know more, not less. If I just say to a patient, I don't know, when they ask a question, they're just going to leave. But if I answer the question with, I'm not certain, but it could be this, and it could be this, right? Give them two examples, not necessarily real close, two disparate examples that show plausibly it could be a lot of different things, right? That is my both personal as well as professional response to things like that. This is just a quickie. We're not teaching neuroplasticity, but neuroplasticity is an effect. Not an effect. It's an aspect of all of our interventions, period. We are relying on neuroplasticity to be able to be a part of why change happens in our patients. Now, the literature is very clear. Neuroplasticity is stronger in younger individuals than older individuals. Those are things we might need to be mindful of. So is the sensitivity of touch is different in a younger individual and an older individual. We need to be aware of these things. But I picked some papers here on neuroplasticity when it comes to some of the more general, pardon me, physical type of interventions, as well as that top one there. And the irony of that top paper, which was released in, I think, around September of last year, was I was reformatting my slides before my India talk. And I had that brand new paper on neuroplasticity by Doderi at the top, and briefly went through it over in my seminar. And ironically, Doderi was sitting in the audience, and I thought, how cool is this? But what I want to make sure is that I wasn't completely like wrongly interpreting what his study said. And when we had a chance to talk later, we're talking about understanding that neuroplasticity is an impact in everything we do, even touch-based interventions like this. Okay. The paper by Abrahamson at the bottom, neuroplasticity induced by exercise, and that's been, I think it was a master's thesis in speech pathology. But in that paper, they were demonstrating, now 2017, so it's some years old now, right? That via MRI, you can see neuroplastic changes in the brain in as early as 5 days, right? So that's the macro change. But there's other papers that are talking about neuroplasticity is an in the moment, instantaneous response when a novel stimulus is introduced, right? So, again, how does neuroplasticity come into play with all this? I think it's just one of dozens, if not hundreds of factors that explain the changes we see with all of our therapies, not just manual therapy, all right? Again, here's sort of a rehashing of what I said. Treat the problem, not the diagnosis. I want to just touch briefly on exercise. Manual therapy and exercise, manual therapy and strengthening, they seem quite different, right? Manual therapy is all about making things more flexible. Exercise is about making things stronger. But when we really start diving deep into mechanism of actions, exercise, strengthening is just as complex and nuanced as manual therapy. That paper by Powell is one that I just received about a week ago. And it's a paper about pain, but exercise, when it comes to patients with pain, is typically viewed as, well, we need to make you stronger. If you get stronger, you'll have less pain. There's a logical narrative there, right? When people exercise, they get stronger, and exercise often helps with pain. But there's a gap there. The effects of exercise when it comes to pain have been shown to not be a direct link with strengthening. If you're interested in that paper, it's an editorial and pretty quick to read. Don't hesitate to ask me for it. But it basically expands the narrative that all of this work is so much more complex than just you're tight, let's stretch. You're weak, let's strengthen. Right? Okay, so what I've got here is sort of a compilation video that it's about 5 minutes long. It's videos that I use, well, in some of my promotion, but they give you an idea of some of the things that we do in a class, some of the things that manual therapy can entail, as well as the way that I go about it. What you're seeing in these series of short clips is some with me with anatomy like that, and I just hate hearing myself talk, so sometimes I have to put it on mute. But also then going into some of the techniques themselves, most of them you're going to see expressed in my native way of doing it, and that's slow, static stretching, allowing patient input, allowing awareness to shift, allowing the patient to have time to decide, does this feel useful? But then at the end, there's a video there that we do this at a lot of classes. If somebody is able to bring in a fees device, where we'll have a volunteer who is being scoped. So we're recording the image with the fees, right, internally. But at the same time, I'm on the outside doing manual techniques. And we have a second recording on the outside. So you've got me on the outside doing the manual therapy, and then we've got the images of internal. And then I take those two separate video clips and I align them and match them, and we form them into one so that you can see that when something happens inside, you can see what I just did outside. Those are not necessarily diagnostic. What there's intended to do is say, well, when we do certain things, do you see the effects on the arytenoids and vocal folds? Do you see maybe the asymmetry that's happening? It doesn't display a direct correlation to treatment effects, but if we can bring patient awareness through movement, through sensation, to an area of dysfunction, that's part of what we're trying to accomplish with all of our interventions, not just manual therapy. So depending on what's going on, I may stop and start this video a little bit. Okay.
Walt, we don't have sound for this. Are we
I'm sorry,
meant
what?
to? We don't have sound on this one.
Okay.
Could possibly be because it's going through your ear pods.
Let's try. That's Louis, by the way. Um, my one of my six cats. Okay, let's try it now. Sorry. Um, I got stuff to teach you. We good? I did. I just came in.
Perfect. Yeah, we're good now. Thank
Okay, I'm
you.
going to go back to where I. There we go.
Hand down, in like that. What I'm going to do is come in with hand over hand. Now, Heidi, do you feel that anchoring downward?
What I just did there, sorry, what I just was doing there is something that we call laryngeal anchoring. It was sort of a evolution of something I learned decades ago in a very different way. Right now, we're using laryngeal anchoring for both building swallow strength as well as with pitch glide, etc. We've taken it to the point where one of my teaching assistants, who's out at Stanford in California, is now doing a study with dysphagia on using simple laryngeal anchoring, holding basically pulling the skin down. I mean, it's super simple. We're looking at, a lot of people are looking at as a possible parallel to the CTAR, where we pull the skin down, essentially anchoring the larynx in a downward direction. Hold the larynx down and then have the patient have successive swallows against resistance, right? If that helps, one could say, well, it helps because you made them stronger. They were able to overcome resistance, right? Someone else say, well, you help them because you stretch tightness that might have preventing that. Now, both of those are a little extreme, but it shows you the disparity in the understanding. We don't really know the complete whys of this, all right? Now, unfortunately, when I stop it like that, it gets messy and I lose my place. So let me see if I can find it. Is no. What I did, I just can't. I got stuff to teach you. I got stuff to teach you. What I did, I just came in above and I gently dropped down. I was above or higher right there. And she said, that's nice. And it does, okay, to me, in fact, I can slow things down. And here's where I get Walt's version in here. I can slow things down to. So that is laryngeal manipulation. That's traditionally how it's applied. That's also traditionally how laryngeal techniques are taught, where you're doing essentially shaking the larynx from side to side, and then eventually they'll begin to lower the larynx to see if they can get a more clear voice. All right. The part where we actually stay and do into this tongue here, right? But then the addition of the hook is while I'm pulling out, I'm engaging. And you can see what happens in terms of the line. It's just going to capture it. And it's a very subtle movement like that. Right? You're going to see me twist my hand from side to side. That's the only way I can get one side versus the other. Okay. So I'm going to have you. And if you've never seen these before, we use they're cotton finger cots worn over gloves. They're available not through medical supply places. You can get them through Amazon, and a lot of the Chinese companies sell them very, very inexpensive. I talk about them in the seminar. But what I love about the finger cots over gauze is it improves my dexterity dramatically because I don't have to worry about getting the gauze getting folded up or et cetera, et cetera. The finger cots are something that has really been an asset to the work as I use and teach it. Really get under or slow micro motions. I'm going to now elevate. And it's just that little bit of a rocking motion. If I want to try one side down, and I'm going to compress all the way down again. Now, my fingers right now, they're not doing that harder, harder. So right now we're going into an evolution that's newer for me. My work was always about manual therapy done at rest. Okay, you relax while I stretch you. But over the past 4 or 5 years, we've incorporated exercise, not just as an add-on, but as a core component of it. While we're stretching, we're also doing manually resistive exercises. And I think it is so much, it's relevant everywhere. but the tongue-based work that we're using, working to promote tongue elevation, working to promote what a lot of people feel is proper tongue resting posture, is done externally a lot with visualizing exercises, using tongue depressors or something to go in there and resist. But there's something about using your finger, whether it's in this case, I'm on the side of her tongue asking her to lateralize, but we do a lot where I come in on top of the tongue. And then I ask my patient to begin to elevate or resist my thumb's pressure. And what I can do is when I do that, the entire surface of my thumb is in contact with their tongue, and I can figure out what part of their tongue is working and what isn't. And very often it's the posterior aspect of the tongue. When I say, okay, push up against me, they'll have all their force on the anterior third. And all I do is, what about right there? Can you get that part of the tongue to hit that part of the roof of the mouth? And by using simple cues, blending it continuously with the stretch, it's like this is entirely different work than I was teaching even 5 years ago when it was all about the passive stretch.
Harder. Good. Now I'm going to come in the other side. I'm going to shove her tongue to the left, and now move your tongue to the right. Push against resistance. Push, 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 push. Good. You're not actually doing this. It's as if you're pressing them to.
Whoop, sorry, there's Louis again. I hit the wrong button. What you are just witnessing right there is what I was talking about earlier, what originally got me invited to teach that first class. We're moving into the space behind the larynx. And that's what you're going to see, some of which represented on that fees video that's going to come at the end of the video. Now, where was I?
It's pretty gentle. You will over push in the beginning, but once you get an idea where these bones are, you don't have to keep pushing so hard. Yeah. Now put your finger in your thyroid notch. I'm having Heidi put her finger on the thyroid notch. Popped out on him right there, right? So I would get my fingers here. There's the bone. Now slow, good. Slow. Would you do me a favor? Could you place your hands over mine? And show me what you'd like.
So right there, in a nutshell, is the difference between my approach and traditional manual by inviting the patient to help me help them. What I did, now she is a clinician, et cetera, but she came up as a demo in one of my classes in Japan. She had some issues. I don't remember what they were, but what I strive for, and it takes some explanation before we start, and it's harder with certain individuals. We'll chat about that in a moment, but okay, I think I might know what to do. Sometimes it's okay, the muscle runs this way, so we need to stretch that way. But sometimes that anatomical or logical physiological approach doesn't align with the values of the patient. And by simply inviting them to come up and help me help them, it's a complete game changer. Will every patient do this? No. Is every patient capable of doing this? Absolutely not. Culturally, will your patient population tell you the things I'm asking? It's tougher. The more I travel around the world, the more I understand everyone's not an American, fortunately. But in terms of trying to get, for instance, an Asian population, to have an expert say to you, what do you think, patient? Does this feel useful? I learned that when I teach in Asia, that I have to say different things. I have to encourage the clinician to say, it's okay for you to tell me what to do to help me help you, those sorts of things. All right. So let me just get back to the video.
Yeah. So this is pretty basic. You're seeing the action. You can't quite see what I'm doing, but I'm starting fairly low. And now I'm working my way up. And now we're
Apologize. So that was the first part of that video, obviously. What I was doing was the very traditional laryngeal manipulation approach in the beginning. All right, let me get to my spot. And in a moment, there we go. You're going to see me then evolve into my version. One's not better, but there are more options. When we see the lateralization, we see a very hurried and aggressive type movement within the larynx. That's part about, to me, building awareness. Traditionally, it's about the clinician changing muscle tension, muscle tone, which might be happening, but we're also giving the patient now a very clear ability to say, "Oh, what do you feel as I do this? Does it feel helpful?" And then I'll slow down. It gives the patient a chance to catch up with me and not feel like I can't tell you if it feels safe because you keep moving so quickly. The audio is very poor on this. See it coming up. Okay. I do apologize. The audio on that one is not very good. But what we're doing when we do these demonstrations is not proving anything, right? But if we can create a connection, whether it's at rest, like he's doing right now, later in this video, it's a very long video, we had him begin to voice, begin to swallow, et cetera, trying to then begin to get a closer match on what I'm doing out here with my hands. Does it feel like it's affecting your issue? Does it feel like it's making it more pronounced, making it calmer, feeling like it's easier or more difficult, etc. That's the language I use to try and get people connected to it. All right. And again, I think the more that I do these, the more I share these, I'm getting emails now from therapists, from SLPs who are looking at the potential of this tool, not just to be in terms of the normal diagnostic, but then blending it with manual therapy to see if there's a diagnostic potential within that. All right. So that's Louis. Louis is my favorite cat. I just need to include him in my slides. If you're curious about the work, I don't want to get too silly, but part of the reason I'm here is because I'm teaching my class in Limerick this September. In case you didn't hear, I do offer you, for being a participant in this class, that 15% discount code Limerick 2026. I have a tremendous amount of free information on my website. Free information if you're curious about learning more, free information if you're curious about the literature. And that last bullet point there, the peer-to-peer mentoring videos were something that I began creating about 2 years ago because there's often a disconnect between, okay, I finished a class, Walt, it's kind of neat stuff, but how do I then transition into the reality of working with a real patient? And whether that patient is peds, elderly, performing, right? So what we have so far is about 15 or 16 videos, whether it's an interview or people self-recorded. It's basically speech pathologists who've taken a class and then went back and began applying it on how they did it. The difficulties, the ease, the benefits, all things like that. For instance, there's a woman who is a pediatric speech therapist who got permission from a parent to share some videos of her working with a 2.5-year-old boy with some tongue issues and how she positioned him for tongue work, how she held his tongue, etc. Especially if you're thinking about, well, I don't understand the mechanics of this. How am I going to do it with fill in the blank? All right. So some of those are really, I think, interesting. The one that I think is it caught my attention the most is the last one. It's a video that was shot by with me, and Elpida is her name. She's a speech pathologist in Athens, Greece. She's been to my class twice because she's been my translator the 2 times I've been to Athens. And interestingly enough, Elpida is also a psychotherapist. Kind of interesting combo there, right? SLP and psychotherapist. But when we were going through the dialogue piece and some of the questions that I briefly said to you, what our interview ended up about is more about the semantics of the approach of as a clinician, what does, and as a person, as a human, when someone asks you, does something feel safe, for instance, which is a word I use all the time, what we're doing right now, does it feel safe to you? How are you going to answer that? Which safe do you mean, right? Are you going to injure me? No. Are you reflecting anything that might bring up things from the past? I don't know, right? Those kind of open-ended questions open up the door for, well, we can cover a lot of grounds. The question, does this feel useful? A question I ask all the time. How do people interpret that? And what I like about Alpida's interview that we did was it goes more into the theoretical, almost the philosophy of not just my work, but the work that we all do. And I think it's a worthwhile video to watch. Anyway, so I got lots of resources, etc. And I think, yep, that's it for my presentation. Let me get out of the share mode here. And well, look at that. I'm ready to bow at an hour. See, Kathleen, you asked me how long I'd take. I said I had no idea, but probably about an hour.
No, brilliant.
What about you? Do you have questions for me? And if you don't feel like you want to put your voice on the chat right now and ask in the group, just want to tell you, I make myself very available for follow-up from talks like this, through social media, through my website, which is waltfritz.com, et cetera, et cetera. I I love what I do. This is not work to me. This is a passion, and I love sharing it, even if it's not about. Okay, let me just get real crass. Selling you a seat in my seminar, right? I love people to understand the nuances of this work, and how it can apply to your work. I tell people that shared decision making, that what you learn from me, I don't want it to just apply in manual therapy. I want you to take those concepts of shared decision making and see if you can begin to spread them out across the work that you do. All right. Can we do this with a nonverbal developmentally delayed child? Yeah. In my class, we talk about how communication and interpretation of nonverbals can sometimes lead us along those paths that we need to be on. Again, my days in developmental disabilities and early intervention, I can't ask that child or adult, does this feel safe? Does this feel useful? We got to work harder. We got to rely on caregivers. We have to rely on our own meta of our experience to then apply it to the N of one of the person in front of us. But that applies across the spectrum of all of your patient populations. All right. Okay. Good.
Brilliant.
Yeah,
Thank you so much, Walt.
you're welcome. You're welcome. And
Um,
it was an honor and a pleasure, and I do appreciate this opportunity, well, to meet you all and possibly meet some of you next year in Limerick. And if not, maybe we'll just chat online sometime.
Absolutely. That's
Okay.
really, I'm sure we could have talked for a lot longer, but yeah, thank you so much for
Yeah.
that introduction anyway. And yeah,
Good. All
your
right. And I
passion is
have,
your
oh,
passion is clearly coming through in what you're doing. So it's
yeah,
really great.
sometimes it's a little overflowing. I know that, but where I am going to make this video available to Kathleen, and I'll also put together the reference list from the class. And remember, if there's any of those papers that you want a copy of and can't get, just send me an email and I'll share it with you. Okay? All right.
Brilliant. Thank you so much.
You're welcome. Bye.